virtual Grand Rounds, and I'm extending a warm welcome from a very snowy Ottawa, in fact, for those of you who are outside the city. This is a special day for us. It's our 9th annual Global Health Conference, and in a few short moments, Heather McDonough will introduce our speaker for Grand Rounds. But before that, I would like to introduce our CEO, Alex Munter, who will welcome you to the Global Health Conference.
So welcome everyone on this snowy morning for most of you, except for Paul. What a strange moment in time it is for us all, and more important than ever to join in this kind of venue for this kind of discussion. I think one of the things that is, if I reflect on past global health conferences and discussions of different challenges faced around the world, of course, the entire world is confronting the same challenge at the moment. And I think one of the things that's so interesting is the degree to which many developing countries have done much better than many developed countries at confronting the pandemic. A reflection of the fact that no matter how sophisticated your healthcare system is, the determinants of health so often lie well outside of the healthcare system. So always lots to learn. And I think, as we are so preoccupied this year here in Canada with our challenges with the pandemic, with the impact of the pandemic on children's lives, even if they've not been infected, children are very affected by pandemic measures. I think it's really important that the thoughts of the CHEO community continue to focus on the needs of children's health here, but also around the world. And I'm always delighted that this conference is very multidisciplinary, including, of course, physicians, but also other disciplines. There's a physiotherapist presenting today, for example, and taking a broad view of what we can learn from around the world and apply here and vice versa. So thank you to Heather, who really is the engine driving this train at CHEO. Thank you, Heather, for all of your great work this year and for many years. And I'll turn it over to you to kick off the conference. And I think you're mute.
There we go. Perfect. So good morning, everyone. Thank you, and to Alex and Dr. Duffy for both welcoming us here today. I have the pleasure of introducing our Grand Round speaker. Dr. Jen Brenner is a friend of mine for over 10 years, and she's a pediatrician and former director of Global Maternal Newborn Child Health at the Alberta Children's Hospital, as well as a clinical associate professor in the Cummings School of Medicine at the University of Calgary. Over the past 2 decades, she's led implementation, research, and policy-related health and development projects in collaboration with East African partners through institutional partnerships that we will hear about today, such as Healthy Child Uganda and Mama na Mtoto in Tanzania. She's held past leadership positions within the Canadian Pediatric Society Global Child and Youth Section, and served as an expert advisor and reviewer, including to the Council of Canadian Academies, Global Affairs Canada, the Micro Research Initiative, and the Canadian Partnership for Women and Child's Health, CanWatch, which is a federal government derivative. In 2018, she was well recognized with the Canadian Excellence in Women and Children's Health Measuring Impact Awards from the federal government CanWatch, and was named a prestigious member of Canadian Women in Global Health list from the Canadian Society of International Health. I think it's a testament to her work that hundreds of Canadians have engaged in global health and development through her initiatives. And on behalf of the CHEO community, I welcome Dr. Jen Brenner to our conference.
Thank you very much, Heather. Thanks to Dr. Munter and Dr. Duffy as well for your kind words and for the opportunity to be here with you today. As I am, all right. Okay, so as I'm presenting today from Calgary, just before I start, I'd like to acknowledge the traditional territories here in Calgary of the people of the Treaty 7 region in southern Alberta, and that includes the Blackfoot Confederacy, which is comprised of the Siksika, Piikani, Piikani, and the Kainai First Nations, as well as the Tsuut'ina First Nation, the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations, and the city of Calgary is also home to the Métis Nation of Alberta Region 3. Now, today I'm looking forward to sharing with you experiences from partnerships who have received funding through a number of different organizations, including Global Affairs, the International Development Research Center, and many private donors and other funding agencies. I don't have any conflicts to declare. But I do want to mention that obviously the partnership and project successes that I will talk about today have resulted from many, many years of teamwork between colleagues in East Africa at partner institutions, as well as the communities where we've worked. And as Heather mentioned, there have been hundreds of Canadian pediatricians, professionals, and staff who have been alongside me on my journey from across Canada. And I will be talking a little bit about, especially my latter part of the presentation, about my personal reflections on global health and partnerships experiences. And some of the ideas I will present have been influenced by conversations with team members, and others are from my own perspectives. And I say that in this context because, you know, I myself, a privileged Canadian in a leadership position, have a certain perspective as I will talk about today. So the objectives I'd like to cover today include providing an overview of Canadian East African partnerships, reflecting on lessons learned and innovations, especially those during 2020. And I'm also going to recap some at the end of my presentation with some concepts of global health and partnerships, looking through the lens of 2020 and what that has shown us. And my presentation will be divided into three parts. The overview of the partnerships. And I'm excited, in this part of the presentation, I will share one short video with you. I'm then going to talk about some of the ideas, innovations, and lessons which have resulted from the shifting practices that we've seen in 2020, some of which were referenced during the introduction, which resulted from COVID-19, from the pandemic restrictions that have occurred, and also the growing momentum within some of the anti-racism and Black Lives Matter campaigns. And then lastly, I will touch briefly on some of the concepts and how I think concepts of partnership and global health have evolved as a result of the experiences this year. Now, this is an image of the silver lining of 2020. And this is a concept in our family that we've used to sort of look at how we can reflect on the changes that are occurring. And this is an image picture drawn by my son, who's 9 years old. And one of the morale strategies we've tried to add to regularly in a list of things that we have learned from COVID-19. And I hope that I can bring some of this type of reflection into the conversations today, because I think that looking back at 2020 in hindsight is an opportunity in many ways for us to accelerate some of the changes and momentum that can actually make global health even stronger and increase its potential in the years to come to better help children, youth, and their families around the world beyond the difficulties that we've faced in this past 9 months. So before I start, I just wanted to sort of open up the conversation with to generate some thinking about what global health and partnership actually means. So I'd ask you to just sort of reflect for yourself on what does global health mean and what is a global health partnership. I also have been for some time myself personally interested in thinking about balanced and equitable partnerships and what those look like. And these have been particularly topical in the work that I've been involved with this year. And whether you're thinking about a partnership that's a personal partnership, a relationship, a partnership here in Canada or internationally, this idea of what does balance look like in a partnership and how does that translate into practice, I think becomes really important as we think about moving forward globally. So in this first portion of my presentation, I'd like to showcase 2 partnerships that I've been extremely involved with. The first is Healthy Child Uganda, and the second is Mama Namatoto, both located in East Africa and have involved our university, the University of Calgary, other Canadian universities, and East African institutions. And both programs have maternal child health focus, have been involved in initiating multiple programs and projects. And both of these, in my view, have been highly productive in terms of both their outcomes and also the academic successes that they have brought forward. Now, Healthy Child Uganda is a university-led partnership together with an institution called Mbarara University of Science and Technology, which is located in Southwest Uganda. And this partnership actually began as far back as 2002 and was a spin-off from a Canadian Pediatric Society collaboration where Canadian pediatricians were traveling to Uganda to support hospital-based training and clinical care in a facility and a university where there really were no pediatricians at the time. There were very few in the country, even fewer at this hospital, and so Canadians supplemented care there. This actual entity of Healthy Child Uganda was a partnership and has continued to be a partnership with the Canadian Pediatric Society and Canadian universities, and evolved to be able to deal with some of the community challenges that were emerging and needs that had been identified by Ugandan partners themselves. And so we were fortunate to be able to bring forward an initial proposal and subsequent proposals incrementally that dealt with some of the issues that our Ugandan partners at Mbarara University were expressing as priorities for the children in their communities. And so while the partnership began small and with basically 3 different partners, the partner activities involved primarily training volunteer community health workers who were individuals selected by their own communities, usually mothers with young children, quite often farmers or people who lived in these communities and who came for some semblance of training and then went back to their own communities to share knowledge, help to triage children when they were sick, and to help initiate health activities in their own communities. And this partnership has, as I mentioned, evolved. And over the years, the activities have grown exponentially. We have been fortunate as a partnership to receive funding from a number of different sources. And this is added to the complexity, but also the excitement of what is now really a Ugandan-led entity that runs programs in health districts, large health districts, which is almost like a kind of a province or a municipal functioning unit, and also activities at health facilities throughout the southwest region of Uganda, and particularly emphasizing the community focus still with a large network of community health workers. So, as I said, there are a number of activities, and central to these activities are some important premises. One is that the activities emphasize local priorities. So, excuse me, priorities are not established by the partnership or by Canadian partners, but by local teams themselves, and particularly leaders within these health districts who approach this partnership for support in different areas as they evolve. There's also been, we've really been focused on integrating within local systems and particularly within local government systems. So we've taken a real health system strengthening approach to the work, and this has evolved over time. I'd say more and more we realize the importance of this practice and how it contributes to sustainability, and the ability of districts to develop capacity that they can use going forward into their own areas of priorities, even though we prioritize maternal, newborn, and child health, and more recently adolescent health. That may not always be the priority of the districts. And so building health systems and strengthening those existing systems at all levels has been integral to our work. We also work closely within national priorities. And so all the programs that we are involved with really have to do with translating policy and guidelines into practice. And we try to integrate different innovative training methods and even to some extent technology. So a big piece of our programming has involved simulation training and the use of low fidelity simulation, sometimes mobile devices, and then working not only to develop these programs and implement them, but evaluate them and think about how these different programs and ideas that have been tried and have been evaluated, to think about how they can be scaled up more broadly and to make recommendations then to policymakers. And within this partnership in particular, it's also been interesting because in addition to the service component and the work in communities, there's been a big piece of this partnership that has involved developing academic capacity. We've been involved in a number of joint student programs, resident programs, an undergraduate field school. There's different faculty exchange, subspecialty training, and quite a bit of joint research that has happened. This initiative has also led to the development of a maternal, newborn, and child health institute, which now houses the Healthy Child Uganda program. And so there's a whole group of experts in maternal child health at this institution in Southwest Uganda who are able to then take on different programs in maternal, newborn, and child health. Our largest program to date was back in the period of 2012 to 2015, when we had a large Canadian funded grant through Global Affairs Canada that enabled us to scale up a sort of comprehensive package of maternal child health activities, which we then were able to implement together with district leaders in 2 specific districts in Uganda. And I'll explain in a minute, but what basically happened was we were able to develop a model and document this model, which was effective in improving maternal child health outcomes in rural parts of Uganda. And then we were able to translate that into similar programming in Tanzania. And very exciting for us now, we've been able to adapt that model. And starting this year, in 2020, we received funding to scale up programming that's similar, but in the area of adolescent health, which is a high needs area in Uganda. So the scope and scale of what we've been involved with has been quite significant. You can see here our reach numbers. This is from the program that we delivered in 2012 to 2015. There were also, in addition to sort of the output numbers that you see here, lots of volunteer community health workers, over 5,000 of them trained and still working. There are also impressive health outcomes. So for example, we sometimes measure outcomes like antenatal care. There was an increase of 22% in antenatal care over this period, significant decreases in the incidence of pneumonia, diarrhea, malnutrition. But what I'd really like to emphasize is that the potential for sustainability in this program. So of the 5,500 volunteer community health workers in this area that were trained, we've since gone back and measured retention, and over 85% of those volunteers are still active. And so I'm going to share a little bit about what that looks like here. And rather than telling the story myself, I'm going to just give you an example in this short video, which uses a format called digital storytelling, which has also been a model of dissemination that we've been experimenting with. So this is a story of one group of volunteer community health workers. In Uganda, they're called village health teams. So they use an acronym called VHTs. And they work closely with another group called local councils. And the acronym for that is LCs. And so this short 3-minute video tells a story told by Molly. And Molly actually worked together with our teams to create this story. She wrote the story herself, and you'll see it here.
okuruga kare na kare omu kyaro kyaitu kya Butoha abakazi bingi bakabaturana babonabona ahabo kutagiraho kuzaara abingi bakabazarra omu byaro abamwe babatwara rugazi abo babahekera bugagara ahabw'engyenda mbi abamwe bakabazarra omu muhanda abamwe bafeera omu muhanda nambwe nitwe twine abaana bingi abakweta bakamuhanda haza ekintu ekyo kikatuura kikunsaasa munonga kunabire ndi aho hijo omuranga gwa gavumenti nakugira ngu nibenda ba VHT omu kyaro nanye natunga chansi nashanga natooranwa nka VHT ekinarebire nk'omugisha ngu bimwe bintwire ninyenda nibibasa kushikirira aho niho hiziire ekitongore ky'omwana n'amagara marungi bakatureetera omushomo ogwabire nigukwata aha mukazi oku yakweteekateekera okuzaara kandi ekintu ekyo ekyabe kituura nikinsaasa wanyuma tukageraho orukiiko rwa ba VHT kwenda ngu tute mu nkora ebi batwegiisa twikirizana ngu tugureho amagaari nari piki kuyamba abakazi biitu oku bakwasa kutambura bakahika hirwaro kwonka twabura kwikirizanaho twagira ngu ekyo nikibasa obutatuyamba ahabwokuba twine obu turayesije kutureeberera piki n'egaari yiitu ebyo kwonka omuri ekyo hakaba hariho ekizimbe kya LC2 nari ekyomuruka nayorekwa ekiteekateeko ky'okugira ngu twakugenda tukaganiraho na chairman LC2 tukamushaba ekizimbe ekyo ite nka ba VHT tukabasa kukitebeekanisa tukakihindura maternity abakazi biitu bakabona aho kuzaarira hiihi aho twahikirira abashaho abari bari aha mwanya ogwo kandi batuheereza obuhabuzi bw'okuza district twahika district twagamba DHO nawe yayakiire ekiteekateeko kyaitu kuyaheereze kwakira ekiteekateeko kyaitu twagaruka enyuma twashitama twagira ngu reka tukoreho fundraising obundi tukabona ahi twayiha sente nitwe tutandikiraho nka ba VHT. Fundraising egyo buri VHT akateekaho omutwaro gumwe kwenda ngu n'abandi batandikireho, kandi n'abantu abu twayesire boona baturaganisa n'abamwe batuheereza, konka tukareba sente ezo zitakubasa kutumarira. Twaza omu maramizo goona n'omu community abantu buri omwe yabaire naabasa 10 bazingahi boona bazituheereza. Twatandika okwombeka obwe tukukozesa emikono yiitu na n'esente ezo twabaire twine. Omurimo gwitu ogwo gukeemerera ahabw'okugira ngu esente tiziratumarire. Mbwenu kutwabaire tukiri aho ab'ekitongole ky'omwana n'amagara marungi bagaruka bashanga turi aho turemereirwe, batukwata aha mukono batwiha ahi twabaire twasya, batukorra, batumaririza ekizimbe kyaitu hati obu kiri aho kihwire kandi abantu boona bashemereirwe ahabw'okuba abantu babwine hiihi ahi bakubasa kuzaara.
Okay, so that's just a small example of what you can imagine happens in these many communities with over 5,000 of these volunteers, and just inspiring for me to see what communities can do for themselves. And that's really the premise of Healthy Child Uganda. And in fact, for this story, we weren't even aware that this whole development was going on and that this community had done something for themselves until the very last moment when they needed a little bit of help with some finishings for this building. So there are many, many success stories like that. And that's, I think, what keeps us motivated in the work that we've been involved with. So another partnership, this one in Uganda, or this one in Tanzania, pardon me, Mama na Mtoto means mother and child in Swahili, builds on the same concepts and has had quite a lot of similar programming to Healthy Child Uganda. Initially there was a longstanding partnership between the Catholic University of Health and Allied Sciences in Mwanza, Tanzania, and the University of Calgary, who'd worked together on some Masters in Public Health training. And then we were able to develop further the partnership when an opportunity arose through Global Affairs funding to conduct some scale-up activities. And so basically what we did was to model a similar program to what had been experienced and successful in Uganda, and including our Ugandan partners who became technical advisors to this project. And alongside other Canadian partners that you see here, this consortium initiated something similar and in some ways larger in scale in Tanzania. And we were also fortunate to get a research grant or several research grants that went alongside this project, so we could study outcomes carefully. And this project has just wrapped up in the last 2 months. We've been working hard over the last period of COVID-19 to do some of the final touches on the project, but essentially this has involved similar types of training at the district level around maternal newborn child health data transport, and at health facilities training, especially using simulation and some other techniques for health facility workers, and then of course establishing similar networks of volunteer community health workers. In Tanzania, over 1,500 community health workers have been involved, and there have been over 500 health workers trained. There also were academic activities involved with this partnership, student training, lots of implementation science type work, and there have been some pretty significant spin-offs, and the partnerships in simulation and some of the relationships between our Ugandan partners and Tanzanian partners have continued and will be further developed. And we measure things like main indicators to say how well a program like this is working. And here you see the numbers before and after for some of our key indicators, which in this case included antenatal care, whether mothers chose to deliver at a health facility, and postnatal care. And all of those showed statistically significant increases within 2 years of the implementation in these areas. And here's just a quote, which you can read, that just highlights how significant and the impact can be in projects like this. So those are the two partnerships that I'll highlight further as we go through. And I'd like to talk to you now about what some of the emerging ideas, innovations, and lessons were that, with hindsight, came as a result of the situation in the world over the last 9 months. So, as we know, the world has changed during this time. We are in the process of closing out these 3 major projects we have and starting a new global affairs funded project for adolescent health in partnership in Uganda. And then there are these ongoing programs. So what happened for us and how were we influenced by what I'd say were 3 really major groups of activities? One is the COVID-19 pandemic itself. 2 were the restrictions and public health limitations that were put into place, particularly the travel bans that affected us. And thirdly, a very strong momentum around anti-racism, which occurred during the same period. So I don't need to tell anyone what this is an image of. 2020 is a year of major change everywhere. This image of the COVID-19 virus is immediately recognizable to a huge proportion of the world's population, but also sort of has brought a new understanding around concepts in global health that would have been completely unfamiliar to most Canadians on this day a year ago. And I think a shift in general thinking about the idea of that health is global has happened, that disease knows no boundaries is no longer a hard sell to communicate. It's pretty mainstream. People who never thought about how their health is influenced by the health of people continents away may think differently now. And not only that, but I think there's been dialogue even around some of the harder concepts. Once maybe an interest to global health keeners, like some of the people on this call, now lay people talk about concepts of herd immunity, R naught, PPE, index cases. This is conversation around the dinner table. And the daily news feed has surveillance data. People who didn't even know what a medical officer of health was a year ago now recognize their public health leaders in the same way as we do with our political ones. And accompanying this has even been some encouraging increased conversation, I believe, around social, racial, and geographic determinants of health, both here in Canada and abroad. And so there's more obviously that can be done to emphasize these issues of equity and influence of the social determinants. But I think that my momentum in dialogue is encouraging and enables us to build on some of this momentum and be able to further articulate what health equity means. And that's a really core concept and core to the being of global health. And so the general public's understanding of that helps to make the case for, I think, why global health matters. So here we were, this is us on March 11th in Tanzania. We're involved with the dissemination of our major project outcomes to policymakers, an event that had been planned for years to showcase the experiences that we'd had in Tanzania. with the Mama Namatodo initiative. Notably in this picture at the top, there are public health specialists from 3 different countries, Uganda, Tanzania, and Canada, all embraced in this conversation, and perhaps we're naively enjoying our last days of normal while we're sharing and experiencing these learnings. And as we headed back to, I mean, of course, this is the period of time when, this is the date, when the WHO declared COVID-19 to be worthy of being called a pandemic. And so as we all marched back to our respective homes, a day or two later, what happened? So in Canada, we went back to 14 days of isolation, whereas our Ugandan colleagues, who are also the equivalent of medical officers of health, went back to face the pandemic in their own communities. So what did they do? Well, they all went back and immediately activated long-standing district outbreak plans. While in Canada, our public health officials were hard at work preparing videos and posting guidelines about PPE donning and doffing for those of us who had very little experience with this, our Ugandan facilities were well versed and practiced in PPE, and they already had the mandatory widespread guidelines posted. Everybody knew how to use PPE. Nationally, the leadership activated very consistent messaging in Uganda. They closed the borders. They instituted surveillance and quarantine using already established contact tracing processes, centralized disease reporting and sample collection. They instituted social distancing, mandatory masking, curfews. And months later in Uganda, there were only a few cases that had been reported and that the disease spread had been contained. Why is this different from Canada? Well, there are many reasons cited for this difference. And of course, today cases everywhere, including in Uganda, are on the rise, although the deaths from COVID are relatively minimal compared with Canada. So while the response in Uganda, wasn't perfect, and the lockdown certainly had serious repercussions, a coordinated pandemic effort in such a poorly resourced setting seems strange. This is a ward in Uganda, and you might think, well, when we struggled so much here with managing the pandemic, even with our seemingly unlimited resources during the early days, how did Uganda manage to contain a spreading pandemic? And some of the answer, not all, but some of it lies here. I'm not sure how many people will recognize if we have any infectious disease specialists here on this call, but this is the Ebola virus. And this has plagued Uganda and its neighbors many times in the last decades, along with measles, polio, Lassa fever, and other infectious diseases. And our Ugandan colleagues, including those medical officers I showed you earlier, were able to quickly pivot and apply their general capacity and preparedness for this outbreak management. And this builds on a concept in implementation science that we call readiness, that when even resources are few, when you're ready and you've got some structures in place, and all of us in capacity development programming try to build this capacity with the activities we do, you actually can respond to emerging needs, even if they're not in the same area. For example, maternal newborn child health or Ebola, it is reassuring to see that investment during programming can shift focus. And so this really was re-emphasized for me and has been a take-home point from the outbreak, that readiness is critical. Ready health systems can pivot to meet emerging needs. Another concept in global health that I think this reaffirmed is the fact that there was so much expertise in Uganda and other parts of the world who had experienced prior outbreaks. And that illustrates a concept that's central to strong global health partnerships. And even thinking back to the considerable expertise that brought us through the first wave of this pandemic, much of that expertise was borrowed from learnings and lessons from low-income countries. Ideas of contact tracing, social distancing, effective facility measures. Many global health activities that we have focus around an assumed expertise gradients, and we expect expertise and innovation and knowledge to move in one direction. Commonly, we think about that moving from a rich country to a poor country, if you look at GDPs. And yet, I think we can do global health better when we have bilateral sharing of ideas and expertise. And I think COVID-19 is an example where, with nearly 1/10 of our GDP, some parts of Uganda seemed even more prepared for COVID-19 than at least I felt here, and was a stark reminder of how our partnerships need to constantly think about how we can facilitate idea exchange and learnings, much as occurred during COVID-19, because there really is so much that we can learn that can benefit and accelerate global health if we look to the expertise that we have within all of our partners, including those in the rich countries and those in the poor countries. Now, another shift that we took during the COVID-19 pandemic was really the direct impact for us of travel restrictions. So pre-COVID, almost by definition, global health involved travel. And face-to-face meetings were often touted as being critical to partnership. But this really had to change. I mean, we had challenges with many platforms, and I don't know what the differences were with travel or with technology that made this possible, but Zoom platforms began to really work well for our teams where other platforms had failed, and similarly other platforms have come along, but this has revolutionized how we do business. So now what was once this travel period that involved several weeks of travel and meetings together has evolved into suddenly being replaced with Zoom calls for us every morning, and has been a breakthrough in terms of presenting new opportunities. So this includes a huge reduction in overall travel time, environmental impact, how we cost our programs, also who contributes and learns. So there's more dialogue now, we talk together, more people can be involved because Zoom calls can reach people who can't travel. It reduces the burden of having blocks of travel in global health. And it really provides different opportunities for different people to be involved, including on the Canadian side, where people can provide technical involvement and research support where they may not have had the chance to travel before. Maybe even more important is that this has expanded in-country opportunities too, where we've been able to leapfrog, and now meetings can occur with some of our rural partners where they can get input into planning and research opportunities right from the start. And we've also been able to engage stakeholders at the national level through these calls. And this type of platform has also, even in the last 6 months, really accelerated the transition so that our partners, even the most junior partners, can attend and present at conferences and be participating in webinars, etc., and have their voices heard. So this has been very exciting for us. It has not only led to changes in how we plan, but also how we conduct business. And this has been a big impact for us in terms of how balanced our partnerships really are. Do we provide enough opportunities for our in-country partners to lead? Here is the initiation, the baseline needs assessment that we conducted this year and needed to happen before we could start project activities on our adolescent initiative, being conducted completely by our Ugandan team. Here you can see respecting COVID restrictions. And this was all carried out completely through the leadership of our Ugandan team, with regular communication and technical advice provided remotely by our Canadian teams. And in all stages of planning, both the startup and the close down, our teams have in both Uganda and Tanzania have proven more than capable and have exceeded our expectations, even under very difficult circumstances of managing our projects, of conducting a lot of the technical work themselves. And it's helped us to think differently about what our role is as Canadians in the service component of the work that we've done. We no longer tokenly involve people. They really have a very meaningful way. And I think it's helped me to reflect on what type of engagement we have, whether it's in orientation, training, technical expertise, and how we can, in a very meaningful way, build even more on the in-country expertise that we had. And it's a different way of looking at partnership. And so I think for us, we can now think of different innovative ways to maximize our in-country participation and then to complement that by technical support. And it's a much better model, whether we're talking about activities here in Canada or internationally, and reduces the back and forth travel significantly. Finally, the movement of Black Lives Matter and anti-racism was very instrumental in helping, at least me personally, and I think lots of organizations within Canada, think about how we have structured not only international development, but international health and our partnerships over the past many years. Global uprisings against systemic anti-Black, anti-Indigenous racism, they've basically held a magnifying glass up to this legacy and structure of power relationships and how the wealthiest nations and help historically disadvantaged countries. And I think it's brought a lens for us to look and say, where are the sources of systemic bias, racism, and discrimination that are embedded in the concepts of global development and global health? Although partnerships are often seen as a structure to promote equity, do they go far enough? Do they really address some of the paternal attitudes and practices that are part of what has historically been global health practice? And this, for me, has been led me to really challenge my own assumptions personally and also professionally within our partnership. And there's been a real call to action, not only for looking internally at our partnerships and what can be done differently, but also how we can advocate for systemic change that can actually strengthen our partnerships. So there are a number of areas where I have personally thought a lot about how we can better do business, and whether this is talking about research, authorship guidelines, striving for a minimal contribution of 50% of authorship from our respective partners, putting in support so so in-country partners can be more engaged in a meaningful way in research and can share in the publication of that research, whether that's the reciprocal relationships we have in exchange with students. Are we really doing enough? Are we being fair in how, when we're sending students and receiving students, are we meeting financial, are we showing financial fairness in the expectations we have of our partners and what they contribute to our, through out-of-pocket costs, and do we give them the same benefits that we have here in Canada for projects that we're working on together? On our steering committees, do we have fair decision-making, and are we involving in-country partners in a meaningful way? And then do our communication strategies and our materials really tell the stories fairly and avoid racism? I think this is an area I've thought a lot back about. A few months back, one of our in-country staff members identified that in one of the photos we wanted to use for our website that one of the little girls who was being showcased, who was very cute and beautiful, she was not one of the children with rust-colored hair or hollow face or flies. She was a beautiful girl, but her skirt was torn. And she wanted us to fix that because she thought that was very disrespectful. And I think for us, that was part of our stereotype of an African child playing in the dirt. But she helped me to realize that that was not acceptable. And so how can we change our communication so that we're fair and we're not perpetuating biases and stereotypes? And then on a more systemic basis, how can we promote equity within our programs and our institutions? I know in our own global health unit in Calgary, we're currently reviewing our strategy aiming to incorporate more anti-racism, equity, and other critical concepts into our programming and also into our pre-departure training. So I believe that this is still an area that needs more conversation, where we can really make a difference in our partnerships and where we need to think hard about how we're doing business. I've now mentioned these innovations and lessons, and I'd like to just wrap up with sort of a quick reflection on 2020 and these two concepts that I mentioned at the beginning: global health and partnerships. And so looking in through the lens of 2020 and our experiences, out of necessity have emerged these new opportunities to think, to know, and to do differently. Global health is no exception. This is Copeland's definition from the Lancet in 2009, which I think is still a fair assessment of what global health is: an area for study, research, and practice that places priority on improving health and achieving health equity for all people worldwide. But I would like to say that as we start to embrace the concepts of global health, perhaps we eventually will find redundancy in the word global, and really all health is global. And so I think COVID-19 has really brought that to the forefront, that disease doesn't know boundaries. We are influenced globally, or by the actions and circumstances globally, and equity needs to be a core concept in all our global health practice, or our health practice and research practice. And I would be personally quite happy if eventually the term global was lost and it just became the norm, that concepts of equity and health for all became something that we all think about as practitioners. Partnerships too, there's lots we can do to continue to push the agenda on partnerships. I think they're a great way to mobilize change, and with balanced partnerships, I hope that I've been able to share that there is potential, that there can be great successes, and that learning can go both ways. And to close, the idea of silver lining on 2020 appeals not only in our personal lives, but also to our professional lives. And I hope that we can take forward some of the lessons that we've learned and build on the momentum of these 2020 experiences in our global health practice. Thank you very much.
Thank you for your really excellent and thoughtful presentation, with almost no text slides, which I was very impressed by. We can open it for questions, and I'm sure there's lots of comments or questions that people would like to convey. There is one in the chat around really looking at as to whether COVID has led to more efficient utilization of our financial resources.
Well, that's an interesting question. I think one area that COVID has perhaps helped us to understand more about is the value of investing in strong health systems. And I think that's a cross-cutting theme that applies both in the global context in low resource countries, where we have seen over time that the most valuable investments we can make is in strengthening these systems that can then, as I mentioned before, pivot and respond to needs. And I think the same can be said about Canada. The places where COVID has cost us probably the most has been where there have been gaps in our health systems. And so I think we have a lot to learn from our partners and how they have been able to manage in low-income settings. I mean, for example, the community health workers I mentioned are core to the surveillance work that is done for contact tracing in places like Uganda and Tanzania. And perhaps those are ways that we can build to help reduce costs in our own existing systems and can over the long run prove to be cost effective. But I see here in that question, there is a lot more we can do remotely in our global health partnerships. And I think reducing travel, increasing our use of in-country partners as core experts in the technical work that we are involved with can certainly save us money in our global health activities and can help us to think differently about who can be involved and how.
I just had a question around the structure within the University of Calgary and the support for a fairly large group of people who are engaged in the process as to how is that funded?
Well, most of we operate our programs in Tanzania and Uganda under what is now known as the Indigenous Local and Community Health Office. And most of the funding is project related. Some of it does come from our faculty and from departments. So I think it's a bit of a mismatch of funding, particularly in our project activities. A lot of it has come through different grants. And increasingly grants and funding sources that the Ugandan and Tanzanian partners have secured for themselves. So we've been fortunate to have these large global affairs grants, but there are also opportunities to tap into UNICEF funding, different charitable organizations and foundations around the world. And so increasingly more grants are coming to our in-country partners themselves.
Thank you. Toby, you have a question.
I put it in the chat, but a great and thoughtful talk as always, Jen. And my question was just, you know, Healthy Child Uganda has always been for many, many years a leader in building capacity and really truly successful bilateral partnerships. And that's obviously evident in the huge impact it's had as an organization. For people who are either our own faculty working on projects locally or for residents who are getting started, any advice for them in terms of practical first steps for setting a good foundation if you're setting up a project where you want to really think about some of those elements of ensuring that the partnership is truly truly successful and bilateral?
Well, I don't know if there's a magic bullet. I think there are new, I think starting projects with a foundation of a partnership and thinking hard about how that partnership works, really investing in the partnership itself, you know, really is important. I think once you have that structure in place, then you can start to increasingly become confident with building trust and understanding and processes into what's done. But I think what's been interesting for me is to look at some of the new materials that are coming out around partnerships, around equity, and even the language that has helped me a lot around racism and some of the more recent dialogue that's been happening has helped me to really think more critically and put language around some of those hard concepts, like how decision making occurs and ensuring that we don't carry bias, and that priority setting really and mutual benefit really come both ways. So I think, to me, it's really about thoughtfulness and not rushing to start something. And for residents and students who want to become engaged, it's about learning as much as possible about what some of the challenges can be in equity and in race and in some of these practices. And I am quite excited by some of there's a new framework coming out from the Canadian group who's involved in international cooperation that I think will start to set some standards for how we do business, and measuring different indicators along the way, including how regular check-ins about how partners are feeling, and whether there are processes to be able to have dialogue or for people to put forth concerns as they emerge. And some of those will make a real difference, I think, in how we operate.
Heather, you have a question.
Thank you, Jen. Just one thing, thinking about principles of global health, like you were saying, building sustainable partnerships and sustainable development. You mentioned that the busiest time in Uganda, because I've heard about Healthy Child Uganda for a while, was 2012 to 2015, and I think maybe that was around your Muskoka Initiative grants and those partnerships, and that we scale up and then you move that to Tanzania. What happens in Uganda after 2015 when that big grant finishes? Are you at a level where the scale up is sustainable in Uganda, or is there like a little bit of a backslide after that? I've always been curious.
Yeah, it's an interesting question. I mean, we've been fortunate, and some of our sustainability planning actually had to do with building structures into the Healthy Child Uganda system, and primarily that was through developing an institute for maternal newborn child health at the university, which is a more strong structure that can kind of manage some of the ebb and flow of project cycles, because that's a huge challenge in global health. You also don't want to be running after grants just for the sake of running after grants. You want to run after grants or look for sources of funding that meet the needs of the communities you're working with. And so there's a real risk if you're going from grant to grant of that ebb and flow, as you said. We were also curious about what would happen at the community level in terms of that ebb, which now, of course, we've got this new adolescent program, which is quite an exciting addition. But what happens to the momentum in the communities? And I think that's where putting a lot of thought into embedding capacity building within existing structures occurs, because those community health workers that were trained do not just sit dormant because there's no longer a project. They report and always have reported directly to the districts and to the health facilities and to their communities. So their work has not stopped during that time. There are other programs that come in. It might be a water and sanitation program. It might be a reproductive health program. It might be that there's an emerging need in the community. They were used, as I mentioned, for COVID-19 response. There's been Ebola and other activities. And if you can keep those groups busy, and if they're part of an existing structure, then they have a role to play regardless of whether there's a project going on or not. And that's why when we went back to look 5 years later, we were pleasantly surprised to find that 85% of them are still active. And the majority of the people who have left actually have left the community for reasons unrelated to project work, or their work as community health workers. So they're still there. You choose the right people, you invest in people who are already in the system. It's a lot easier to get through those periods where there's not as much going on. And they don't work, community members, health workers, districts, they don't work for a project. They work for the system that they're in. And so that's been key to being able to think about sustainability and this idea now of being able to pivot.
So I just want to say thank you very much. There are a couple of questions in the chat, but I'm going to hand it back to Heather, because clearly the conference needs to move on, and you can let me know if you want to handle the couple of questions that are outstanding, or whether you need to move on from a time perspective. But I'd just like to thank Jen for her outstanding talk, and really very, very wonderful work that you're engaged in, and I think we'd all like to congratulate you on that.
Thank you so much, Jen. That's terrific. Yes, I know. Virtual, virtual applause. Amina, one of our residents, was just talking. I like that question about many terms using to describe the link